two muscles attach up here? It's one muscle to head, right?
Yes, you too.
Okay, a superior head and an inferior head. Into the disc, only one of those muscles attaches. Remember which belly? It's on top. Good, it's the superior head of the lateral pterygoid. What we know is, though, that only about 20% of the fibers attach into the disc. The rest come and attach into the condyle. The other one, which is much, much bigger, the inferior belly, attaches into the condyle. That's the muscle that moves things around. They function differently. What we know is that if this condyle is going to move forward, okay, I'm coming down the eminence, and of course the disc has to reposition itself so it's in the right place, okay? That what's going to happen here is that the inferior belly is firing, but the superior belly is not. It releases when you open. When you close, the superior belly fires. So when I start coming back up the eminence, the superior belly is firing. Can you see why it might want to fire? Because if you think about what happens to this disc as I open, what is it doing? As I translate. By the way, if I rotate, okay, I have to hold this still. Because if I rotate, only the lower compartment has action. The upper compartment stays in place. As soon as I translate, things start to move. So as you think about what the disc can do, think about it as being hooked on the sides incredibly firmly. But if I move, it's going to allow this thing to move and reposition itself where the load is applied. That's in protrusive. If I go laterally, so let's say that the brain is over there, so this is medial. As I move laterally...
Wait, here, I'll be the brain.
I was going to say that. But I knew it would be a leap for you. Okay? As I translate now, in a working movement to that side, I'm now the translating condyle, right? Which means I'm going to be moving at an angle, this way. The path is different than protrusive. In fact, I bet you have patients that if you ask them to move to one side, they can't. But if you ask them to protrude, they can. And you ever wonder why? It's a different path. If you think about what's happening up here, my first thought would be, well, wait, if there's something blocking their movement as it comes down, why doesn't it block their movement that way? Because this thing doesn't just sit in 2 dimensions. It can do all kinds of stuff. So let's talk about the most common thing that happens. Again, if the brain is over there, and it could be
Okay.
the brain is over here, this is lateral. The most common thing that happens that we see is we get something called lateral ligament laxity, where this little portion begins to move a bit. And it's living tissue. Even though it doesn't have blood vessels or nerves, it's living tissue. And it tries to adapt to that. We are highly adaptable, thank goodness, because if we weren't, we'd have a real problem. As this comes down like this, when I move into a movement, all right, remember that the load, if I bite down and squeeze, where's the load? Over here. So this is hanging here. Is it being moved around at all? Actually, no. There's very little, if any, force. Now, there's some, because this is all squishy. So I squeeze like crazy. This is where the load happens. I relax, I start sliding down. The load starts moving out across. As it moves out across, because the force is coming out here, what do you think this disc would want to do? Pop. Actually, it wants to pop back. Because in an early ligament laxity, the positioning is still such that it grabs the right spot. In other words, the right anatomic structures line up, and what this does is goes pop and goes back into place throughout the movement. Then as you come back up, it will ease off again. In reciprocal clicks, often, we hear the first one loudly. Hear the second one almost always with less intensity. The reason for that is that as you're coming back, what's happening on this side? It's being unloaded. So force is being removed. If you remove the force, there is no compelling push for this to do this. It does it because it has been repositioned a little. Now it can get more severe. It can get to the point where it's way out, so that as I open, what happens? It never And that is a non-reducing lateral. We use the word pole, and my problem with pole is when I think of pole, I think of a spot. It's not a spot. It's really an aspect. So if you think about this as having a lateral aspect and a medial aspect, it helps me think in 3 dimensions. This side could stay up, so it may make no noise. It may happen really late that it recaptures. Which means that if I am a restorative dentist and I'm thinking about what I'm going to do to somebody's occlusion, and I may cause some changes in load inside that joint, one of the things that I want to know is, where is this disc and what does it do? Because an early opening, late closing click is not nearly as worrisome for me as a late one, because it implies that this is less displaced, if you will. Now, this side could be off by itself. Usually, this side is not, but it can be. The only instances that I have experienced of medial aspect displacement without lateral aspect displacement are trauma. What can happen in some patients, and for years we believed there was this cascade, boom, 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 boom. If you get this, you're going to get this, then you're going to get this. We now know that is not true. Some patients go through this cascade of events where the disc is displaced, it causes inflammation, it displaces more, eventually the medial displaces, eventually this is bone on bone, actually cartilage in the middle, which then goes away, and you get to bone on bone. We now know that that only happens in people who are susceptible for that to happen. Many people will go through a stage where this becomes displaced or lax and may never go further, ever. So, as we think about what's happening in joints, the most important thing to remember is that if I understand what's happening up here, I can start to make some decisions about how stable my result could be if I need to treat teeth. I also might decide that I really don't need to treat teeth. Because how do you judge stability? Yeah, what's going on? If it's reproducible and it's stable, I'm pretty comfortable that things aren't changing. And I've seen some very, very stable joints that make noise. Now, sometimes the noises change, but there's one thing I discovered when I started trying to treat temporomandibular disorder patients. If I treated noise, I usually fail. Because if I treated the same joint sound, thought it was happening in the same place, and I did that 99 times, on the 100th one, the noise wouldn't change. And what I've learned is it's a very, very, very individual thing, because it's about adaptability of these structures. Some people adapt. Some people do very well with a click and a pop, and they don't really overload things. They just roll over it. Some people destroy joints. So today, when you're with your partner, I hope nobody in this room has really terrible joint stuff. But sort of in sort of a perverted sort of way. I hope somebody does, so that we can talk, so that we can grab them and talk about it. I know we have one in the room, and we can probably get together and be able to see some things, so that we can experience what something looks like. So again, what I'd ask you to do today is, in your mind, as you're thinking what's going on with my partner here, the person that I'm being the dentist for, if you will ask yourself, where is the disc, and what is it doing in translation, protrusive translation, and what is it doing in excursive lateral translation? If you get that process into your brain, by the way, without necessarily initially making decisions about what it means. At first, just experience that you know what's happening. It'll go a long way toward helping you decide if occlusively there are things you can do to help stabilize this. Because my goal is to stabilize the joint wherever it is. Because I want to do the dentistry. I'm first and foremost a restorative